Hey y'all, so male reproductive disorders fall under, or types of male cancer fall under two types. There's prostate cancer and testicular cancer. However, we're only going to go over testicular cancer. And we want to discuss risk factors, identify signs and symptoms, talk about screening versus post-discovery care, surgical care, pre and post-op. Okay, so what is prostate cancer? Well, prostate cancer is a cancer of the prostate. The prostate is an organ that surrounds the male urethra. It's a set of glands surrounded by smooth muscle. So it sits just below the urinary bladder and before the pelvic wall. So what I want you to see is that in most other statistics, you'll see that the number of new cases and the number of deaths are quite similar, right around the same. However, the risks of a man dying from prostate cancer are quite low. It says 1 man in 41 will die of prostate cancer. And that is because it tends to be a diagnosis in older men, and they will usually die of some other comorbidity before they will die of prostate cancer. So your primary risk factors are aging, well, being a male, aging, and being an African American male. And remember, it's very important that not likely to die from prostate cancer, but from something else. So here's your pathophysiology slide. Most prostate cancers are androgen dependent, so they do work off of androgen, and they're adenocarcinomas. Most of them are pretty slow growing. We'll see that in younger men they tend to be more aggressive tumors, and most of them tend to occur on the outer aspect of the prostate gland. It can metastasize via direct extension into the lymph nodes or the bloodstream, and these are I got some examples here down below. So into the seminal vesicles, the urethra, mucosa, bladder wall, or external sphincter, and into the bloodstream, the pelvic bones, head of the femur, lower lumbar spine, and legs. So we see the prostate here. This is a side view. It can metastasize down into the urethra, up into the bladder and the bladder wall, into the regional lymph nodes, and back into the bones or the hips. And then also can metastasize to the liver and to the brain, but mostly more regional, around into the urethra, the bladder, and the spine. So risk factors. Family history is a risk factor. So that's genetics. Age, remember, the older a male gets, the more riskiest for prostate cancer. Those with a history of a vasectomy, that can put you at risk for prostate cancer because we've been messing around and genetic modification can occur. Ethnicity, African American males, and a high-fat diet. Clinical manifestations at first are usually asymptomatic. Here's an example of this, the majority occurring on this outer wall. Late symptoms can include BPH-like symptoms. So remember, BPH is benign prostate hypertrophy. And so those include symptoms like urinary urgency, urinary frequency, or hesitation, being unable to start a stream because of the tumor can be impinging on the urethra. Lower back pain and lower back fracture, and those can be as a result of cancer metastasizing to the bone, and now, of course, the tumor has weakened the bone. There can also be sexual manifestations of this, and that's usually what seeks a man to go get help. So things that can affect or symptoms going into them, again, remember urinary frequency, especially at night when they're laying down, difficulty starting urination or holding back urine, so that hesitancy and incontinence, a weak or interrupted flow of urine, so not being able to have a strong stream, painful or burning urination, difficulty having an erection, even painful ejaculation, blood in the urine or in the semen, and frequent pain or stiffness in the lower backs, hips, or upper thighs, everywhere that prostate cancer metastasizes to. So, excuse me, a kind of new thing on the scene is genetic testing for this. And I thought this was interesting that they said that there is a link between certain types of aggressive prostate cancers, and that BRCA1 and BRCA2 gene, those genes that are the same in breast cancer for women. And so that's kind of interesting. There's some links down here about that. But the biggest thing is that screening should begin, if you have a family history, screening should begin at age 45. No family history, screening begins at age 50. And when I say screening, we're talking mainly about these two things, which is a digital rectal examination, because that's the only way to examine the prostate, and then the prostate surface antigen. Prostate specific, I don't know, I keep saying surface. Prostate specific antigen here. So we're looking for any kind of elevation at all with the B in the PSA, any kind of enlargement at all, or hardness or asymmetric enlargement or nodes or anything on the digital rectal exam. The TRUS is a transrectal ultrasound. So that's also examining for any lesions inside of the prostate, being able to visualize it. This is the only way, like we can do a CT scan, we can do X-ray, all these things for visualizing different parts of the body, but when it comes to visualizing the prostate, the best way to do that is to do a transrectal ultrasound. So that includes bowel prep the night before and doing a couple enemas. Then they come in and the ultrasound probe, a very thin probe, is put into the rectum and the prostate is examined. And then of course, once the prostate has been examined, a prostate biopsy can be performed the same way. It's done transrectally, or if there's another area of metastasis that we're suspecting and the symptoms are late symptoms, an MRI and CT can help pick up those areas of metastasis, and a bone scan as well. And the last type of scan is looking for prostate-specific antigens. Grading and staging, this gets into that Gleason pattern scale here, but it also gets staged on a stage 1, 2, 3, and 4. And just like with any other kind of staging, the higher the staging, the worse the cancer. Gleason pattern basically talks about the differentiation. And remember, we've said and established very well that the more poorly differentiated a cell is, or the less differentiated a cell is, that the worse the cancer and the more aggressive it can be. So treatments, sometimes when the cancer is very small, there may be or we just have enlargement of the prostate, but no tumors were noticed. May just be follow-up with the physician. And that's what our watchful waiting is. Also, if you have an older man with not very aggressive prostate cancer, it may be left alone. Because remember, older men tend to be diagnosed, and they also don't tend to live very long after being diagnosed, primarily due to dying of other cancers. Surgical things that can be done after cancer is diagnosed would be a transurethral resection of the prostate. So this is just a going in through the urethra and cutting out the prostate from the inside and removing it. A prostatectomy, which involves an incision on the outside of the body to remove the prostate, or cryosurgery and freezing of the area. And then radiation, and radiation can be done with these little tiny radiation seeds in there. All those little things are providing radiation, and even hormone responsive things, because remember, it is the prostate does respond to hormones just like the breasts do, and so the hormone therapy to block PSA receptors to keep the tumor from growing can also be initiated. So here's an example of a transurethral resection of the prostate, and these are what you'll probably see the most common besides a prostatectomy. So it goes in right through the urethra, and they remove all of the prostate, and it's just left. So pre-care is pretty standard. They will have general anesthesia for this. Post-care, however, the patients must be instructed that they will have a urinary catheter. They will have a urinary catheter. It may or may not be a three-way catheter, meaning that we're used to seeing a Foley catheter with one end on it to attach to the Foley bag or the drainage bag, and then one end to blow up the balloon. Well, you can have three-way catheters, and that can help instill an irrigant into the bladder or antibiotics. And that's what the continuous bladder irrigation is, the CBI. It's normal for the urine to be blood tinged, and that's part of the CBI, is to keep things well irrigated so there's no blood clots in there. And the patient may or may not have bladder spasms. So our role as the nurse would be taking care of this patient post-operatively, would be managing that urinary catheter, looking for any signs of obstruction in the catheter, keeping the CBIs going, calculating our INO from that, and managing the bladder spasms with medication. Our discharge teaching is very important to let the patient know that they will have their catheter removed at their first follow-up appointment. They are not to drive until the catheter is removed. They are most certainly not to have sex with the catheter in. This has happened. Or to make sure that they're taking care of the catheter, so that includes washing it with soap and washcloth and drying well, just like you would any other part of the body. No heavy lifting, no lifting over 10 pounds. It's our general surgical post-op care anytime there's an incision. Report any signs or symptoms of infection. We know what those are. No sexual activity for 4 to 6 weeks, and they are at risk of bleeding, so they do not resume their blood thinners until resumed by the physician. So that's our transurethral resection of the prostate. Prostatectomy incisions can be a suprapubic or a retropubic approach or a perineal approach. So those are all different ways that you can do a prostatectomy. Remember, because we will be going in by the bowel area, that we now have standard but plus clear liquids and the bowel prep, just like they would do with the TRUS, the transrectal ultrasound. Post-care, also urinary catheter, may or may not be with CBIs, most likely not, and they would also have an incisional drain, usually a Jackson-Pratt drain. Discharge teaching would include no tub baths for 2 weeks or instructed by physician. Same with our treatment our discharge teaching with the TURP. About sex, catheter care, no driving, may have burning with urination afterwards. A big thing that makes sure that our patients know about is prostatectomies. Patients are most certainly going to end up incontinent. Our hormonotherapies. Here's our LH and our LHRH antagonists and agonists. Androgen receptor blockers or treatment with estrogen to help inhibit the LH secretion. Orchiectomy, that would be removing the testes, and that's to remove the source of testosterone. Remember, we said these are primarily androgen-fed tumors, so androgen receptor blockers are very important and most often used. And as an alternative to an orchiectomy, estrogen can be used.